Ruchi, and let me thank Professor Malik, Professor Ruchi Goyal for giving an opportunity time and again. And I think this is the 9th year in succession we are doing this IC and AOS conferences, and every time the hall is very full, and every time it's a very small hall, and this time I think we have to thank Dr. Lalit Verma for providing a very big hall for us, and it is a very, very important course. And my talk is going to be on PCR, prevention, recognition and management of PCR. My talk is on the DVD here, so if you want, you can collect the DVDs at the end of my talk or end of this session. It's on this head table. But before I start the talk, I want to know how many of you have not had PCR at all? There's one guy there? No. If you have not had PCR at all, only 2 reasons. One is you are telling lies. Second, you are not doing cataract surgery at all. So, early recognition combined with advances in instrumentation have enabled to management of posterior capsule rupture. As I told you, it can occur during the hydrodissection and during the nucleus removal, during the cortex removal, and during the posterior capsule vacuuming, which is very, very common, and also during the cortex removal, IOL implantation. If you leave the PCR like that, or if you don't manage it properly, you can have cystoid macular edema, retinal detachment, endophthalmitis, secondary glaucoma, and all these problems can occur. And that's the reason why we should be able to take care of this complication, which is not uncommon. Please understand this. Okay, depending on the novice and on the experienced surgeon. Even experienced surgeons can get this PCR. But the difference between the ordinary and extraordinary surgeon is how you manage the PCR very well, and you can give 20/20 or 6/6 vision for these patients on a long-term basis. So, sudden deepening of the AC, loss of lens fallibility, lens tilt or deepening of the posterior chamber. So, I have developed this what is called the 10 commandments, and I'm happy to say that I got the best video award from ASCRS for this 10 commandments last year in Boston. So the commandment number 1, please watch these videos very carefully. See this part of the video. This part of the, you can see there is a sudden deepening of the anterior and the posterior chamber. You're able to see that? The sudden deepening. If there is a sudden deepening of the anterior chamber as well as the posterior chamber, that indicates that that is an underlying PCR, an underlying disaster for you. Number 2, you can see that the lens does not come into the port, despite the fact that you are having a very high aspiration flow rate, like 40 ml per minute or 45 ml per minute on the mission, on the peristaltic mission. The lens does not, there is a loss, sudden loss of lens fallibility. Okay? If there is a sudden loss of lens fallibility, it means that there is an underlying PCR. So these are the indications. So this is again a very, very important thing. The pupil snap sign, which is a first telltale sign, sudden contraction of the pupil during hydrodissection, especially in posterior polar cataracts, or if you have a small rhexis and a huge brown cataract. Don't try to do hydrodissection. What happens is the entire fluid goes into the posterior capsule and pushes the nucleus up and blows out the posterior capsule. It's called the blowout or the capsular blowout or acute capsular blockade syndrome. So this has been seen. And also, how do you anticipate traumatic cataract, posterior polar cataract, bullseye cataract post-vitrectomy? Hard brown cataracts and the capsule is not very good, the capsule is thin. All these conditions, or pseudo-exfoliation, small pupils, these conditions you should expect or anticipate posterior capsule rupture in this. So, 3 important conditions avoid hydrodissection. Do hydrodelineation or don't do anything. Like posterior polar cataract, bullseye, the traumatic cataract, previous vitrectomy. Nowadays, even Avastin or Lucentis injections, sometimes we have seen that sometimes you touch the lens without unknowingly, and these patients can have a posterior capsule rupture. Be careful of these post-vitrectomized eyes and post-lucentis eyes and post-avastin eyes, there is a possibility of a PC tear there, and also make sure that you don't do hydrodissection. What do you do when you have a PC tear? Normally people become jittery, the surgeons become jittery. So avoid removal of the instruments quickly, lower the bottle height, remove the phaco handpiece slowly from the eye. If it's a small tear, convert that tear into a posterior capsular excess. This is a patient who had a posterior capsular plaque. So I tried to open the posterior capsular plaque and he had a tear, and then what I did was I converted that into a small capsular excess, posterior capsular excess. A posterior capsular excess is much more stronger than a PC tear. So you can, just like the anterior axillary excess, the posterior capsular excess is also very strong, and you can go ahead and put the lens in the bag in this. So what do you do when you have a PC tear? You have a vitreous there, you do a bimanual vitrectomy. Don't do a coaxial vitrectomy. I will tell you why. Because if you do a coaxial vitrectomy, more and more vitreous will start coming into the anterior chamber, like a tsunami. So then the posterior capsular tear, which was initially about 2 millimeter, will become 7 millimeter or 8 millimeter, and you will not be able to put a lens in the bag. So, but you do a bimanual anterior vitrectomy. Bimanual means have a irrigation separately, like what he showed. I think Ruchi also showed, and Professor KPS Malik also showed. Have an anterior chamber maintainer. What will happen is that this will tamponate the brake and also prevent the hydration of the vitreous. So it will tamponate the brake and prevent the brake from enlarging if you are an anterior chamber maintainer. So high cutting rate. Nowadays cutting rates are coming 2000, 2500, you need a high cutting rate. Commandment number 3, as you can see the date also, 2007, one of my phaco trainees was doing the phaco. There is a PC tear, he didn't notice that. And there was also a part of the nucleus going inside. So what he did was, that like normally everybody will do, is that he saw that and he knew that there is a PC tear now, and he pulled out. See this? Don't pull out. If you pull out, what will happen is the initially small tear will become a huge tear, and more vitreous will start coming into the anterior chamber. I went in and did a bimanual antivitrectomy. Fortunately for me, the nucleus piece started coming up. I will cover that a little later. What is command number 4 and 5? See this. Again, this video was taken year 2000. I was operating on a union minister, and you can see the last piece of he had a very dense brown cataract. You can see the last piece. When I take the last piece, because of the post-occlusion surge, which Malik was mentioning, and there is a PC tear. Can you see the PC tear there? Okay, it's like a posterior capsular excess. But I didn't become jittery. I remained calm. I introduced viscoat through the side port. Okay, introduce viscoat or whatever viscoelastic you have. Viscoat will plug the hole. Introduce viscoat and gently withdrawal of the phaco handpiece from the eye. So this stabilizes the anterior chamber. This prevents the PC tear from extending. Then make a right side port. Right side port, don't go through the main port at all. And operate bimanually and use I did the anterior vitrectomy at that time. The tricot was not available. So I did the anterior vitrectomy. You can see the PC tear is the same in the beginning, same in the end as well, and I was able to put an MA60 lens in the bag, and the patient was doing well for almost 13 years. What happened to it after that? Because he died. Okay, that's a different issue. But what I'm trying to say is the long-term 6/6 vision I was able to give for this patient from 2000 to 2014. Okay, number 6. What is number 6? Bimanual technique is very, very important. Don't go coaxial. Coaxial means or monoaxial. Malik was telling that. Use the bimanual technique. Use the bimanual IA. Remove the vitreous first and then remove the cortex later. Remove the vitreous which is there. You don't have to be a posterior segment surgeon. Many people come and ask me, sir, I do not know anterior vitrectomy. It's very simple. But only thing is use a posterior vitrectomy probe, not the anterior vitrectomy probe. All the phaco machines are now coming with the posterior vitrectomy probe. Use the posterior vitrectomy probe and use the right side port. You can see commandment number 7. Use triamcinolone acetate, preservative free, is available. Orocort is available. I don't have any financial interest. Use it in the beginning, okay, not after you do some vitrectomy. Use it in the beginning itself. If you do some vitrectomy and then use the tricot, the entire tricot will go back, and you will have a secondary glaucoma in these patients, which will be very difficult to manage. Number 8 is, number 7 again is a tricot, you can see here. Number 8, you can see here, bimanual anterior vitrectomy. Bimanual cortical aspiration, bimanual anterior vitrectomy. Use a posterior vitrectomy probe. Nowadays is available as a 20 gauge, 23 gauge, 25 gauge. Whatever is comfortable for you, use a posterior vitrectomy probe on the right side, make a right side port and have an irrigation on the left side so that you can clear the vitreous. You can use the triamcinolone. Triamcinolone will be able to delineate the vitreous which is there in the anterior chamber, and you can just cut it off and cut and move forward. Don't cut and pull. If you cut and pull, there will be traction on the vitreous face. Cut and move forward, and so that with a high cutting rate, I'm sure you will be able to do a good job. So number 9, what is number 9? Once you have done this vitrectomy, then you know what is the amount of capsule, anterior capsule, whether the anterior capsule is intact or how much of the posterior capsule is. Assess the capsular integrity. Sit back and relax, because your adrenaline is flowing and do not know what to do. Sit back and see how it is there and how the capsule, how much of capsule is there, how much of whether the capsular axis is intact, whether you can put a lens in the sulcus or a lens in the bag. Number 10, once you do that, then you put the suitable IOL. If it's a small tear, then you can put a single piece in the bag. If it's big tear, then you cannot put a single piece lens in the bag. You have to put a multi-piece lens. Don't put a single piece lens in the bag, in the sulcus, because this can produce secondary glaucoma, uveitis, and all this UGH syndrome, all these problems. This is again, I'm putting in the sulcus. You can see a multi-piece lens, is an MA60 lens, because I have lost a huge amount of the posterior capsule in this particular case. So again, you can see, you can put an iris fixation lens. I do the iris fixation lens retro, not anterior. Posteriorly you can fix up, or you can put even a glued IOL, which has been described by Amar Agarwal, which is a very beautiful technique which I am using regularly, or a suture scleral fixation depending on the capsule. Or in the worst situation, do an anterior vitrectomy, put an anterior chamber IOL, nothing wrong. Make sure that you do a good anterior vitrectomy and do a peripheral iridectomy in these patients. So these are the 10 commandments I would like to, I wanted to highlight, and these are the things. The take-home message is, this video highlights that the various scenarios of the broken capsule management are the same, with the good post-operative visual outcomes. So anticipate in traumatic cataracts, posterior polar cataracts, brown cataracts, and all this. Moral of the story, this is what I have mentioned earlier. And if you manage this and follow the 10 commandments, you will have a good life. You can enjoy a good night's sleep. Otherwise, the patients will screw the life out of you. Thank you very much. Thank you. Happy New Year to all of you.